So what I'm going to do is complement a little bit what the previous speaker has mentioned in terms of soluble or circulating biomarkers that just an idea for sure on the imaging. Now Peter has nicely set the stage and mentioned to you the major molecules that are involved in atherosclerosis, and we know that in the vascular wall they adaptively determine assisted two-paro, and so the role of these molecules in the vascular wall, I think, is fairly clear, and I will focus a little bit on some of these molecules. I cannot cover all of them because it's quite a lot of those. I focus a little bit on risk prediction based on these markers. Now what's very clear is that in addition to the local process of atherosclerosis an inflammatory process in the vascular wall, that we have a low-grade systemic inflammation that we can measure with high sensitivity assays. And for the sake of time, I have to select some of these that you see on this slide. It's quite a number of them, but I will briefly talk about fibrinogen, white blood cell count. IL-6 is of specific importance. IL-18 oxidized LDL, LPPLA2, interesting molecules. Then myeloperoxidase, MMPs, MCP1. Those are the ones that I selected. As you see, there are many others, but time is limited. Now, I'd like to start for historical reasons with this paper. It's a New England Journal paper from 1974, and Dr. Friedman and colleagues have looked into approximately 500 persons in whom a first myocardial infarction later developed. They had measured the white blood cell count 1.5 years before, and what they found is that the mean leukocyte count in cases was significantly higher compared to the control group, and even more important, already at that time, they could show that the increase in risk conveyed by increase in leukocyte was similar to what they could show for cholesterol, our traditional risk factor, and high blood pressure, just to name the two of them. So I think even at that time, it really documents that inflammation may be very important in addition, and this is important too, and I think Peter has already alluded to that, in addition to our traditional risk factors. Now, in the early 1980s, we no longer talked about atherosclerosis, but atherothrombosis, because of convincing evidence that in the final step of the atherosclerotic process, thrombotic component plays an important role. And fibrinogen was the first marker that has been measured in large population. This is an overview that you see here, and by and large, a twofold increase risk was associated. No, a 1 gram per liter increase in plasma fibrinogen was associated with a twofold increase in risk. And obviously, fibrinogen has not only hemostatic properties, but also is part of the acute phase reaction, and therefore it's an inflammatory marker. Now, another marker, easily accessible marker, a neutrophil lymphocyte ratio, has recently gained a lot of interest, and this is data from several studies that has been published a few years ago by Adamstein and colleagues, and you can see here under, if you can, okay, the neutrophils, the quartile neutrophils, and for various endpoints, MACE plus, CV death, and all-cause mortality, you can see some kind of increase. An inverse association was seen with lymphocytes, and if you take the neutrophil lymphocyte ratio in quartiles, you clearly can see, at least if you go into the top quartile, that there is a significant increase in risk. And this has been replicated in quite a number of studies like CANTOS, that has already been mentioned, in JUPITER, INSPIRE, and SPIRE-1 and SPIRE-2. These were large trials with bococizumab, which later had to be withdrawn because of drug antibodies. And finally, the third trial with methotrexate. So quite consistently, and this is, I think, the importance is that it's an easily accessible marker. Now, I mentioned already that in the context of our discussion here, IL-6 is of particular importance, and there are already data from population-based studies, but also in patients with atherosclerosis, and that complements the data that have been gathered for C-reactive protein. And for interleukin-6, what it conveys in addition to C-reactive protein is that we know it plays a causal role. There is interesting data of variants that are associated with impaired IL-6 receptor function. And this is associated with decreased CRP, with decreased IL-6, and also decreased outcomes. And this is a compilation of the studies that have been available or that are available for quite some time, including our data from Augsburg here in the middle. And you see that for one standard deviation increase in IL-6, there was a 25% increase in risk. And similar data have been collected in patients from a large clinical trial. This is stability with daraplatin, an inhibitor of the PLA2 lipoprotein-associated phospholipase A2. And you can see here across various endpoints from MACE till stroke and heart failure, including non-CVD death and also cancer death. Across quartiles, you see an increased risk for outcome, for this outcome when you look into IL-6. So it's not only in population-based studies, but also in clinical trials. And a more recent study in a well-phenotyped MESA study from the US, again, it could be shown if you look at the, oh, that was wrong. If you look at the Kaplan-Meier curves, they are clearly separated on the right side. And if you look into tertiles here on the left side, then, and if you compare the IL-6, the second tertile, third tertile to the reference, you see that there are an increased risk for all-cause mortality, for cardiovascular mortality, non-card, but also incident heart failure. So abundant evidence that IL-6 plays a significant role. Now, in addition to IL-6, IL-18 may be a candidate that's relevant in that context, and you can see that it's intimately involved in plaque formation. It's associated with increased expression of VCAM. It's associated with increased expression of proteinases and plaque instability. So there are a number of mechanistic aspects that are relevant. And this is data from the Cantos showing for various endpoints that they are associated with increased tertiles of IL-6 or IL-18. In the middle, you see IL-6 before and after canakinumab. And I think you will appreciate that the IL-6 in the cardiovascular endpoints is clearly lower after the canakinumab. It's not the case here. But when you look into IL-18 on the right side, before and after, you don't see any changes. Another molecule that has been of utmost interest for long term, especially for basic researchers, because oxidized LDL in the cell, in the subintimal space, we know, and this is a nice paper by Glass and colleagues, we know that the LDL is oxidized in the subintimal space, and oxidized LDL is taken up by monocyte macrophages and finally form the foam cells. And we know that one of the major mechanisms is that it upregulates expression of matrix metalloproteinases, but you can see there are other mechanistic aspects as well. Now, this is one of our early data. This is already 20 years ago that we did a case cohort study, a prospective case cohort study, and you can see if you go across tertiles in various under various adjustments, you see still a significant increase. In particular, if you take tertile, the top tertile to the bottom tertile of oxidized LDL. Now, a molecule that has received a lot of attention, let's say about 10 years ago, was the LPPLA2, lipoprotein-associated phospholipase A2. And it's a molecule that's produced in the plaque, in macrophages, monocytes. and it oxidizes LDL and generates atherogenic molecules like lyso-PC, as you see here. Oops. Lysophosphatidyl-choline and oxidized fatty acids, which are very atherogenic. And they would form the basis for an hypothesis that this might be important for risk prediction. And at the same time, there was daraplatin, an inhibitor of LPPL2 available, and this was followed up then in 2 large clinical trials. Now, this is again data from my group about 10 years ago, and you can see with measuring the mass or the activity across different levels of adjustment, that there is a significant association between LPPL2 at baseline and cardiovascular outcomes 4 years later. Only for the mass assay, when you control for LDL, did not give a clear significant result. This was replicated only more recently, it's 10 years ago, not 20 years ago, but 10 years ago, in the already mentioned stability. And you can see MACE and CV death, and you will clearly appreciate that the top quartile of LPPL2 in this large trial with about 15,000 was predictive for outcome. This was not the case with the lower quartile. So, but there was a clear signal with very much increased LPPL2 activity that this is not really beneficial. And this supported assumptions that intervening with this LPPL2 might result in a benefit for the patient. Unfortunately, as you can see here, when you look at the Kaplan-Meier curves, this was stability, a study in patients with chronic cardiovascular disease who received daraplatin, and unfortunately, for the primary endpoint and also for secondary endpoints, there was no effect seen. Another marker is myeloperoxidase. We know that neutrophils that go under degranulation during acute coronary syndromes do release myeloperoxidase, and you can see a number of mechanistic aspects are related to MPO. It oxidizes LDL, activating metalloproteinases, etc. And this is the data that have been published, also relatively old data, but to my knowledge, there is no newer data. MPO and risk of CHD on the top panel. What you see here is the association of MPO with the presence of coronary artery disease, that is leukocyte MPO and also blood MPO. And then the lower panel, you see prospective data, patients with ACS, symptomatic patients with regular or with normal troponin T, and MPO was predictive for 30 days complications, but also for 6 months regarding risk of CHD. However, and this is a problem with some of these markers, the methodology is not solid enough. So in some of these studies, sometimes it also depends on the size. The results could not be replicated. In this case, this was the case for risk, opus-TIMI, the CURE study, and atherogene. MMPs, an important molecule, I think Peter mentioned it several times. What they are known for, in particular, that they degrade extracellular matrix, and they do play an important role in this destabilization of the plaque. Now, they're useful as markers. Now, this is one study. There are not many studies around. This is one study from Stefan Blankenberg, who at least could show that there is, across quartiles, that there is an association between matrix metalloproteinase and prognosis in patients. Those with Q4 did worse than those with Q1 to Q3. And on the right side, it's quite interesting. You see an association with MP. If you take matrix metalloproteinase 9 above the median, is associated with risk. and the risk is much enlarged when you combine two pro-inflammatory markers, MMP9 and IL-18, sorry, what you can see here. Now, furthermore, and I think this is probably the last marker, is monocyte chemoattractive protein 1. It's also important in atherogenesis because we know that it's able to attract various cells like monocytes, for example, lymphocytes, to the area where you have local inflammation in the vascular wall. And the predictive value could be demonstrated in the Opus TIMI19 study. This was a significant difference, at least between Q4 and the remaining quartiles. So these were soluble markers or circulating markers. And what you can see in this nice overview a few years ago published by Antonopoulos and colleagues, they focused on CRP and IL-6. You have seen data on both of these markers. And obviously all of these inflammatory markers that are shown here do add in terms of risk prediction. And the marker used here is the delta for the C index. But if you look a little bit further down here, we're switching to imaging markers, and you have already heard about PET-CT, and I will briefly focus on CTA, on fat attenuation index, and you clearly can see that these imaging markers seem to be superior to the circulating markers. This may have to do with the fact that you are closer to the atherosclerotic process and more local. It gives more local information. Anyway, interesting development. Now, as I said, I will only briefly focus on CT because the other methods have been nicely dealt with in the last talk. CTA today can nicely demonstrate non-invasively the anatomy, the coronary anatomy, severity of stenosis, etc., coronary calcium. You can also nicely detect various plaque characteristics. For example, the napkin ring, the low attenuation, very important, a very high risk plaque, spotty calcification, and also the positive remodeling. These are important criteria that enable a more precise identification of the so-called vulnerable patient. In addition, functional assessment of stenosis can be done, fractional flow reserve, ICT can be measured. And finally, there is a relatively new method that has gained some interest, the perivascular fat attenuation index on the left side. Now, perivascular adipose tissue, you can see that as a sensor for coronary inflammation through its modification in response to an inflammatory signal that comes from the vascular wall. Although it's a bidirectional process, the inflammation that goes on in the vascular wall modifies the fat that surrounds the epicardial vessel. And the fat attenuation index is a specific marker of coronary inflammation, and you can use regular CTA data in addition to using AI, and it really detects vascular inflammation by mapping three-dimensional changes of the perivascular fat attenuation on CCTA. Now, there are not too many studies around at that point in time. This is probably the most important one, the CRISP-CT study. And what you see here, focusing on the three major epicardial coronary arteries, right coronary artery, left and left circumflex, looking into two different independent cohorts, the derivation and validation cohorts. So a very solid methodological approach. And you have two parameters like endpoints, like all-cause mortality and cardiac mortality. And you clearly can see that all-cause mortality and cardiac mortality are associated with increased perivascular fat attenuation index. This was only not so clear for the circumflex artery. Maybe in many cases it's a relatively small vessel, but that could not clarify it. Another analysis simply looked into these derivation and validation cohorts that I mentioned here, and looked into high and low perivascular fat index, and I think you can nicely see that these curves are tremendously separating from each other. So there's a quite clearly a significant effect. And this fat attenuation index also may be able us to better stratify cardiac risk associated with high-risk plaque features. And if you look at the top right, you can see the different curves. And if you look at the purple one, which separates most clearly, these are patients with a positive or with a high fat attenuation index plus a high-risk plaque phenotype, and that's a 7-fold increased risk compared to those who don't have either of these two phenotypes. I think that was the last one. I'd like to conclude by reminding us that inflammatory processes in the vascular wall are present during all stages of atherogenesis. I think that's very important. And besides this local vascular inflammation, we do have these low-grade systemic inflammatory processes that we can measure by a variety of high-sensitivity assays, starting with C-reactive protein, for which probably we have the largest database, but also IL-6 and others. I'm skipping that one. And in addition, novel imaging methods like CCTA-based FAI may be promising and specific markers of coronary inflammation to further refine our understanding of the local inflammatory processes. So I think that was a short overview, but I think within 20 minutes I hope you have seen that there's much more behind, and we're looking forward to continuous discussions. Thank you.